So we're going to continue. You heard me talking a little bit earlier about immune causes or autoimmune causes of small fiber neuropathy. Now we're going to go a little bit more into those causes. I want to tell you that this is a big topic nowadays. It's gaining importance as we are more and more discovering that there is an autoimmune substrate to many of those conditions that can affect the autonomic nervous system. And we can divide those autoimmune disorders classically into two broad categories. One is the autoimmune rheumatic diseases. And typically these are connective tissue diseases that are in the rheumatological world more than they are in the neurological world. So nowadays, these two fields are kind of overlapping here in what comes to small fiber neuropathy or dysautonomias. And it wouldn't be unusual if you're my patient to see me refer you to a rheumatologist to look further into the possibility of one of those autoimmune rheumatic diseases. If they are confirmed by the rheumatologists, typically they are treated by them as well, because they are much more experts in the treatment of those disorders than neurologists are. So some numbers here. The autonomic nervous system is affected in a wide range of percentages of autoimmune rheumatic diseases. So those percentages can vary from 24% to 100%. And I think that this large difference is due to the type of disease. You know, there are a lot of those diseases, and the methodology that was used in those studies in order to calculate those percentages. But cardio-autonomic abnormalities are found in autoimmune rheumatic diseases in the absence of cardiac disease. This is an important point to emphasize. If you have a autoimmune rheumatic disease, and this is causing you to have a cardiac autonomic problem, like for example, a heart rate variability loss, this does not mean that your heart has a problem and that you're going to die of a heart attack, okay? That's not the case, or congestive heart failure. So the most common one and better known one is systemic lupus erythematosus, or KSLE, which is an inflammatory disease that affects multiple organs. It also affects the psyche. It can cause neuropsych manifestations. But in lupus, the central nervous system is the most affected part of the nervous system, rather than the autonomic or the peripheral nervous system. Now, this being said, there are studies that have looked at autonomic nervous system involvement in lupus, and some studies have come up with that astounding number of 93% of lupus patients having an autonomic disorder. But most of those cases are asymptomatic. So basically, they are found on testing. And there is no correlation. That's important. And I think it's also valid for all these disorders, that there is no correlation with disease activity, with the presence or absence of a peripheral neuropathy, or the presence or absence of neuropsych manifestations. So if you have a severe lupus, doesn't mean that you're going to have a more severe autonomic disorder with it. And the question that really is of importance here is, does a subclinical dysautonomia in lupus affect the quality of life? If so, then it's worthwhile addressing it and treating it. But if it's not, if it's just a laboratory finding, then, you know, we have to ask ourselves, should we really spend time looking for dysautonomia in lupus? And the question that is unknown, also the answer to which is unknown, is how about down the road? Do patients develop clinical symptoms down the road? Is there something that we could do in order to prevent that from happening? So those remain questions without answers. The second is rheumatoid arthritis. We know that about 30% of rheumatoid arthritis patients develop a small fiber neuropathy, and they manifest as cold feet, purple extremities, Raynaud's phenomena, orthostatic tachycardia, like POTS, rarely orthostatic hypotension. All right. In advanced rheumatoid arthritis, parasympathetic cardiovagal dysfunction is seen. Okay, so there are 60% in one study, for example. And sweat output distally in more than 50% can be abnormal. So a small fiber neuropathy, in other words, right? Same thing, no correlation with the duration of disease, the titer of rheumatoid factor, articular destruction level. All right, but you know, just to tell you that this field is not quite understood because you find other studies where there are no abnormalities in cardiovascular autonomic nervous system testing in 43 patients with rheumatoid arthritis. So that's a big number, which makes the incidence of autonomic dysfunction in these conditions uncertain. Sjogren's syndrome is, on the other hand, a better defined condition which has a more definite correlation with small fiber neuropathy and specifically an autonomic neuropathy. According to a study from 2006 by Lopate, 60% of these patients develop a small fiber neuropathy. And there is definite involvement of the autonomic nervous system. In one study, 50% of Sjogren's syndrome patients develop symptoms of autonomic nervous system dysfunction, and 66% had abnormal autonomic testing. Important to say that there's no correlation between autonomic nervous system symptoms and the degree of dryness, decreased salivation or decreased tearing. Okay, so different types of antibodies have been incriminated, including cytokine inflammations, anti-receptor antibodies, autonomic ganglia, anti-nicotinic receptors. So we don't know exactly the mechanism of action of that problem, of Sjogren's syndrome, but we know that there is a clear-cut association between the two. Now, for those who are not familiar with Sjogren's syndrome, so we call it the drying disease. It affects about 3 to 5 million people in the world. People can have dry eyes, dry mouth. We call those SICA symptoms, S-I-C-C-A. And there is a blood test that we can use called the anti-SSA, anti-SSB, which diagnose Sjogren's when they are present. However, they're present only in 1/3 of cases. We rely a lot on a drying test called the Schirmer's test, that where you have a piece of paper, of filter paper that is put in underneath the eyelid, and we measure the amount of tear that has been produced over 5 minutes, and we can know whether there is normal tearing or not. And the other test is the lip biopsy. So this becomes an invasive test, but my patients would know that if I see and suspect Sjogren's syndrome, I will send them to have a lip biopsy, which is about 70% sensitive and compared to 30% in the blood. So we need to have two positive criteria in order to diagnose Sjogren's. So either lip biopsy with a Schirmer or a positive blood test with a lip biopsy, etc. Ankylosing spondylitis is an inflammatory disease of the spine and the sacroiliac joints. It manifests mainly as radiological abnormalities. You can see those abnormalities on X-rays of the spine and the SI joints. It's a painful condition. Mainly, patients would say that they wake up in the morning with pain in the lower back, and it subsides as the day goes on. There has been some reports that have linked this condition with orthostatic tachycardia, with fluctuation of blood pressure, but again, the mechanisms are again unknown in this condition. Fibromyalgia. So fibromyalgia, a lot of people in the medical world would tell you we don't believe in fibromyalgia. Fibromyalgia is not a real condition. And this was okay. I mean, I could understand such a reasoning because it was based on a subjective diagnosis. And the subjective diagnosis was that the patient would say, ouch, if you push on a cardinal point, and there are about 11 cardinal points that are mentioned in the literature on both sides of the diaphragm. And if they have pain when you push on those cardinal points, if you have 11 points, then this is it, fibromyalgia. Until recently, where people are starting to show that there is an underlying small fiber neuropathy to fibromyalgia, so that's becoming more of an organic disease, if you want. It is frequently part of a spectrum of primary disorders of the autonomic nervous system that includes POTS. A lot of things have been described, with fibromyalgia, including loss of circadian rhythm, increased sympathetic sensitivity, decreased sympathetic response to stressors, which can explain increased fatigue, low blood pressure, urinary symptoms, IBS, etc. So I cannot say that it's an autonomic disorder yet, but it is part of a spectrum of autonomic disorders. We are still waiting to see if we could isolate those patients with fibromyalgia, nothing else, and test their autonomic nervous system and know whether they have abnormalities independent from other conditions that could explain those abnormalities. Another condition is called scleroderma or systemic sclerosis. So this is part of a syndrome that we call CREST. And autonomic neuropathy has been well described in CREST. It affects both the parasympathetic and the sympathetic nervous system. I do check for that when I work up a disorder of the autonomic nervous system with an underlying small fiber neuropathy. This condition could explain sleep disturbances and fatigue, GI disturbances, tachycardia. And we don't know at what point in scleroderma the autonomic nervous system becomes affected. Is it early or is it late? And that's the same question that I was asking regarding lupus. Is it an early symptom or is it a late symptom? And in my experience, I see more autonomic symptoms in scleroderma than I see in lupus. All right, so to summarize this section, cardiovascular autonomic dysfunction is common in the autonomic rheumatic diseases. However, the numbers are very fluctuating. Autonomic nervous system dysfunction in lupus, Sjogren's, scleroderma, fibromyalgia, and rheumatoid arthritis are maybe the best defined. Disease duration, disease severity, and damage resulting from the disease to the multiple organs seem not to be irrelevant to predict the severity of the autonomic abnormality. Autoantibodies against the autonomic nervous system could be responsible for the autonomic nervous system disorder. Testing of autonomic nervous system in autoimmune rheumatic diseases is warranted to detect early cardiac autonomic neuropathy. And this is really the only reason, I would say,